If you have been noticing that your feet tingle at night when you are lying still, or that a small cut on your toe took 3 weeks to close when it used to heal in a few days, or that sometimes your feet feel strangely cold even when the rest of your body feels warm, or that the bottom of your feet have a burning sensation that arrives in the evening for no reason you can explain, I need you to stop dismissing those things as ordinary, because what I am about to tell you today is something that most people with blood sugar problems are never told clearly enough, early enough, or in a way that makes the urgency real without being frightening. The feet are where diabetes speaks first, not the blood test, not the dramatic symptoms people imagine. The feet. Months and sometimes years before a formal diagnosis is made, and often years before a person even suspects blood sugar is involved, the small nerves and blood vessels in the feet begin to respond to the chemical environment that elevated glucose creates. They respond quietly, with signals that feel minor, signals that get written off as poor circulation, as sitting too long, as getting older, as needing better shoes. I am Dr. Alex, and today I want to take you through what is actually happening in the feet when blood sugar is chronically elevated, why the feet are affected first and most severely, what the specific warning signals look like before they become irreversible, and what you can do right now to protect yourself whether you have a formal diagnosis or not. Because here is what matters most. The damage that diabetes causes to the feet is not sudden. It is not the result of one bad lab reading. It is a slow accumulation, building over years, invisible to the naked eye until it reaches a threshold where the consequences become visible and serious. And almost everything about that process is preventable or at least significantly slowed when it is caught at the right stage. The right stage is now, not after the numbness has become complete, not after the wound that will not heal has been present for 2 months. Now, while the signals are still quiet enough to be missed, and early enough for intervention to matter most. Let me start by explaining why the feet are affected first, because once you understand the biology, everything else makes a different kind of sense. The human body has approximately 45,000 miles of blood vessels. The ones that matter most in the context of diabetes are the smallest, the capillaries and the tiny arterioles that reach the farthest from the heart into the extremities. The feet sit at the very end of the body's circulatory map. They are the last destination for blood that has traveled from the heart down through the aorta, through the femoral arteries of the thigh, through the popliteal behind the knee, through the tibial arteries of the lower leg, and finally into the small vessels of the foot and toes. That distance matters. It means the blood arriving at the feet has already been under the influence of elevated glucose for its entire journey. It means the vessel walls along that entire route have been exposed to the glycation, the inflammation, and the oxidative stress that high blood sugar produces. And by the time that blood reaches the small vessels inside the toes, those vessels may already be stiffened, narrowed, and less able to deliver the oxygen and nutrients that the nerves and tissues of the foot depend on. The nerves of the feet face the same problem from a different angle. The nerves that supply sensation to the feet and toes are among the longest nerves in the human body. The sciatic nerve and its branches travel from the lower spine all the way to the tip of the toes, a distance of more than 3 feet in most adults. Long nerves require a continuous supply of oxygen and glucose along their entire length. They depend on tiny blood vessels called vasa nervorum, which run alongside the nerve and feed it. When those tiny vessels are damaged by chronic blood sugar elevation, the nerve begins to starve at its most distant end first. And the most distant end of the longest nerves in the body is in the feet. This is why diabetic neuropathy begins in the toes and feet. Not because the feet are uniquely fragile, but because they are at the end of the line, the first to be reached last, the first to lose their blood supply, the first to show signs that something upstream has gone wrong. Now let me walk you through what those signs actually look and feel like in the order they tend to appear, so you can recognize where you or someone you care about might be in this process. The very first signal, and the one most consistently overlooked, is tingling. Not dramatic tingling, not the sharp pins and needles you feel when a foot falls asleep because you have been sitting on it wrong. This is a quieter tingling, a gentle buzzing or electrical sensation that tends to arrive at the end of the day, often in bed, when distractions have faded and the body is finally still. It often starts in the tips of the toes and gradually extends back toward the ball of the foot. Some people describe it as a mild vibration. Others say it feels like something is lightly crawling across the skin without touching it. Others describe it simply as an awareness of the feet, an uncomfortable aliveness in the toes that was never there before and has no obvious cause. Carol was 67 and had been noticing this tingling for about 8 months before she mentioned it to anyone. She noticed it mostly when she was reading in bed at night. A mild buzzing in both big toes that faded when she moved her feet. She assumed it was circulation. She bought new slippers. She tried sleeping with a pillow under her ankles. The tingling continued. What was actually happening in Carol's toes was the earliest stage of peripheral neuropathy. The myelin sheath, which is the insulating layer that wraps around nerve fibers and allows them to transmit electrical signals cleanly, was beginning to deteriorate. When myelin is compromised, nerve signals become distorted. The brain receives scrambled information from the feet and interprets it as tingling, buzzing, or that restless awareness. It is not the nerve dying. It is the nerve struggling to communicate through insulation that is being damaged by the glucose environment surrounding it. And here is what makes this stage so critical. The tingling stage is reversible, or at least significantly improvable. If the blood sugar environment that is damaging the myelin is corrected at this stage, nerve recovery is possible. The body can repair myelin. It does so slowly, but it does it. The window for that repair is open at the tingling stage. It closes as the damage deepens. The second signal is a burning sensation, particularly in the soles of the feet, in the evening or at night. This tends to arrive later than the tingling, and it is more difficult to ignore. People describe it as if the floor they are standing on has a mild heat source beneath it that nobody else can feel, or as if the soles of their feet have been lightly sunburned on the inside. It tends to be worse after a day of activity, worse in warmth, and sometimes relieved temporarily by resting bare feet on a cool floor or a cool surface. Thomas was 71 and described his burning feet to his wife as feeling like he had been walking on hot pavement all day, even on days when he had barely left the couch. He mentioned it at a doctor's appointment and was told it was probably plantar fasciitis and to try arch support insoles, available over the counter at most pharmacies. He tried them. The burning continued. The burning sensation in diabetic neuropathy is produced by a different mechanism than the tingling, though both arise from nerve damage. When certain pain-sensing nerve fibers, called C fibers, become damaged and sensitized, they begin firing spontaneously. They generate pain signals without any actual injury or heat source to trigger them. The brain receives those signals and interprets them as burning, because burning is what those fibers normally communicate. The feet are not hot, the pavement is not hot, but the damaged nerve fiber reports heat anyway, because it has lost the regulatory mechanisms that normally control its signaling. This spontaneous nerve firing is also why some people with diabetic neuropathy experience a sensation where the bedsheet resting against the top of their foot feels uncomfortable or even painful. A sensation called allodynia, where a stimulus that should not cause pain does. The nerve is so sensitized and so dysregulated that even the slight pressure of fabric triggers a pain response. The third signal is the one that moves from discomfort into genuine danger. It is numbness. And paradoxically, it is the signal that feels like an improvement. When the burning and tingling have been present for long enough, when the nerve damage progresses from the outer insulating layer into the nerve fiber itself, the ability to transmit any sensation begins to fade. The burning quiets, the tingling reduces, and people often experience a sense of relief. Perhaps the problem resolved itself, they think. Perhaps it was just a phase. It was not. The silence is the nerve going quiet, and a foot that cannot feel is a foot that cannot protect itself. Margaret was 73 and told her daughter that her feet had finally stopped bothering her. The burning she had complained about for over a year had faded over the previous few months. She was sleeping better. She was walking more comfortably. What she did not realize is that she was now walking with feet that could not reliably detect temperature, pressure, or pain. She stepped on a small piece of gravel in her garden and did not feel it. It pressed into the skin of her left heel with each step for an entire afternoon. By evening, she had a wound she had not known was forming. By 3 days later, it was infected. She had not noticed because the foot that would normally have complained after the first step had no voice left. This is how diabetic foot ulcers begin. Not with drama, with silence. A wound that forms because the foot cannot feel what is happening to it. An infection that develops because the immune response is compromised by elevated blood sugar. A healing process that stalls because the blood supply to the tissues has been narrowed by the same vascular damage that damaged the nerves. Diabetic foot complications are the leading cause of non-traumatic lower limb amputations in adults in this country. And the pathway to those outcomes almost always passes through this moment. The moment when the burning finally stopped and nobody recognized the silence as the warning it actually was. The fourth signal involves the appearance of the feet rather than the sensations inside them. Changes that are visible on the skin and structure of the foot can tell a trained eye a great deal about the blood supply and nerve function beneath the surface. And many of these changes are visible to anyone who knows what to look for. The skin of a foot with compromised blood supply tends to become thin, dry, and shiny. The normal moisture and resilience of well-perfused skin depends on an adequate blood supply delivering nutrients and maintaining the skin's natural oil-producing glands. When that supply diminishes, the skin loses its texture. It becomes almost translucent in appearance. Cracks develop along the heels that are slow to heal. The skin does not respond normally to moisturizer because the problem is not dryness of the surface, but deprivation of the deeper layers. Hair loss on the toes and lower legs is another visible sign that receives almost no attention in ordinary health conversations. The hair follicles on the toes and the lower portion of the legs require blood supply to function. When that supply is reduced, hair stops growing in those areas. This is called peripheral arterial disease, and its presence on the lower leg is a direct reflection of the vascular changes that diabetes accelerates. If you look at the tops of your toes and the lower portion of your shins and notice that hair has stopped growing there, or that it is significantly thinner than it used to be, that absence is not cosmetic. It is a vascular signal. The nails of the feet change as well. Thickened, yellowed, or ridged toenails can reflect fungal infection, which is more common in people with elevated blood sugar because glucose-rich tissue is a hospitable environment for fungal growth. They can also reflect reduced blood flow to the nail bed, and because the toenails of a person with neuropathy may not communicate pain normally, an ingrown toenail or a nail pressing into surrounding tissue can cause significant damage before it is noticed. The color of the feet provides additional information. A foot with poor arterial circulation may become pale or bluish when elevated and red or purplish when hanging down. This color change with position, called dependent rubor, reflects blood pooling in vessels that have lost their ability to regulate flow efficiently. A foot that is consistently cooler than the rest of the body, particularly when one foot is noticeably cooler than the other, is a foot whose blood supply deserves evaluation. The fifth signal involves the bones and joints of the foot itself, and it is the signal that most people have never heard of and would never connect to blood sugar. There is a condition called Charcot foot, or Charcot arthropathy, named after the neurologist who first described it in the 19th century, and it is one of the most serious and under-recognized complications of diabetic neuropathy. It occurs when the bones and joints of the foot begin to fracture and dislocate without pain, because the neuropathy has removed the protective warning system that would normally make those injuries immediately obvious. A person with advanced diabetic neuropathy can sustain multiple fractures in the small bones of the foot during ordinary walking and feel nothing significant. The foot swells. It becomes warm and red, And because those are the same signs as an infection or a sprain, the fractures are often misdiagnosed or missed for weeks. Meanwhile, the person continues to walk on a foot that is structurally collapsing, and the architecture of the foot progressively deforms. The classic end-stage appearance of untreated Charcot foot is called the rocker bottom deformity, where the arch of the foot collapses entirely and the midfoot protrudes downward. This creates a pressure point that is almost guaranteed to develop an ulcer, because the skin in that location was never designed to bear weight, and now it does with every step. Charcot foot is largely preventable if neuropathy is identified and managed before it reaches the severity required for this complication. But it requires that neuropathy be taken seriously long before the bones begin to fracture. And that requires recognizing the earlier signals, the tingling, the burning, the numbness, the skin changes, long before the structural consequences arrive. Now let me tell you about what actually happens in the tissue at a microscopic level when a wound forms on a diabetic foot that has neuropathy and poor circulation, because this is the piece of the story that explains why healing fails and why even small wounds can become catastrophic. Raymond was 74 and had a small blister on the back of his right heel from new shoes. Under ordinary circumstances, a blister heals in a week. Raymond's blister was present for 6 weeks before his wife finally insisted he see a doctor. In those 6 weeks, it had enlarged, developed a hard calloused border, and the center had begun to break down into a shallow open wound. 3 things were happening simultaneously in that wound that normal wounds do not face. First, the blood supply reaching the wound was compromised by vascular disease. Wound healing requires an enormous delivery of oxygen, nutrients, growth factors, and immune cells to the injured site. In a healthy foot, the blood vessels dilate in response to injury, flooding the area with everything needed for repair. In a foot with diabetic vascular disease, that response is blunted. The vessels cannot dilate normally. The flow is restricted. The wound receives only a fraction of what it needs. Second, the immune cells that did arrive were functioning less effectively than normal, because elevated blood glucose impairs the killing ability of neutrophils and macrophages, which are the primary white blood cells that fight infection at a wound site. Bacteria that a healthy immune system would clear in 24 to 48 hours were able to survive and multiply in Raymond's wound for days. Third, the nerve damage meant Raymond could not tell when he was putting harmful pressure on the wound. Every time he walked without protection, he disrupted the fragile new tissue that was trying to form across the wound base. Normal healing requires undisturbed tissue formation. Raymond's wound was being re-injured multiple times daily without his knowledge because the foot that would have complained immediately in a healthy nervous system was silent. The combination of these 3 failures, vascular, immune, and neurological, is what transforms a small wound that should heal in a week into a chronic, non-healing ulcer. And chronic non-healing ulcers are the direct precursors to amputations. Not because medicine has no answer, but because by the time the wound is large enough and old enough to force attention, the underlying tissue damage is often deep, infected, and involving structures that cannot regenerate. This is the trajectory I want to interrupt, not at the wound stage, at the tingling stage, at the burning stage, at the shiny skin and absent toenail hair stage, where everything is still on the front side of serious. So let me now be very specific about what you should do. The first action is a foot self-examination performed every single day without exception. This is not a medical procedure. It takes 2 minutes. But for someone with blood sugar concerns or confirmed diabetes, it is as important as taking medication. Sit down, remove socks and shoes, and look at every surface of both feet. Between the toes, where moisture collects and fungal infections begin invisibly. Under the foot, where pressure points develop. Around the toenails, where ingrown edges can break skin painlessly. The heels, where cracks and blisters form from shoe friction. If you cannot see the bottom of your foot clearly, use a long-handled mirror, such as the Dexterity long-handled mirror available on Amazon or at medical supply stores, or ask a family member to look. What you are looking for is any break in the skin, any redness, any swelling, any color change, any wound that was not there yesterday. If you find anything, do not wait. Call your doctor the same day. The second action is footwear that is actually protective rather than merely comfortable. Shoes that fit properly, with a wide enough toe box that no toe is being compressed, with enough depth that the tops of the toes are not rubbing against the shoe material, and with a firm enough sole that sharp objects on the ground cannot easily penetrate. Orthopedic footwear brands like New Balance, Propet, or Drew Shoes, available at specialty footwear stores and online, are specifically designed with the diabetic foot in mind. Never walk barefoot on any surface, indoors or outdoors, if you have any numbness in your feet. Not on carpet, not on tile, not on grass. The ground has irregularities and small objects that a numb foot cannot detect. A protective shoe provides the warning system that the nerve no longer can. The third action is blood glucose management, with specific attention to post-meal spikes. The nerve damage of diabetic neuropathy correlates most closely not just with average glucose levels, measured by A1C, but with the frequency and magnitude of glucose peaks. Repeated large glucose spikes cause glycation of nerve proteins and oxidative stress in the vasa nervorum, even in people whose A1C looks acceptable. Continuous glucose monitors like the Freestyle Libre 3 or Dexcom G7, available with a prescription at most major pharmacies, show exactly what is happening to glucose levels after each meal in a way that a quarterly A1C cannot. If you have neuropathy symptoms and your A1C is in the borderline range, seeing your post-meal glucose curves could reveal spikes that explain the nerve damage even when the average looks controlled. The fourth action is specific nutritional support for nerve health. Alpha-lipoic acid is an antioxidant that has been studied extensively in the context of diabetic neuropathy and has shown in multiple clinical trials to reduce the tingling, burning, and pain associated with early nerve damage. It is available without a prescription as a supplement. Thorne alpha-lipoic acid and now supplements. Alpha-lipoic acid, 600 milligrams, are both available at iHerb, Amazon, and Whole Foods, and have been used in the European clinical studies on diabetic neuropathy for decades. The doses used in research are typically 300 to 600 milligrams daily. As always, discuss with your doctor before starting, particularly if you are on diabetes medication, as alpha-lipoic acid can affect blood glucose levels. Vitamin B12 deficiency is also directly linked to neuropathy and is extremely common in people taking metformin, the most widely prescribed diabetes medication sold under the brand name glucophage, because metformin reduces B12 absorption from the gut over time. If you take metformin and have tingling in your feet, please ask your doctor to check your B12 level at your next appointment. B12 deficiency neuropathy can be reversed with supplementation, but only if the deficiency is caught before the nerve damage becomes permanent. Methylcobalamin, which is the active form of B12 that the nervous system uses most efficiently, is available as Gero formulas methyl B12 at health food stores and online. The fifth action is a formal neurological foot examination by your doctor or a podiatrist at least once per year, and more frequently if any symptoms are already present. This examination uses a monofilament, which is a thin nylon filament pressed against specific points on the sole of the foot, to assess whether protective sensation is present. If you cannot feel the monofilament at 10 grams of pressure, you have lost protective sensation and are at high risk for undetected foot injury. This is a quick, painless, inexpensive test that takes about 5 minutes and is one of the most important preventive tools in diabetes care. Ask for it by name. If your doctor does not perform it routinely, ask a podiatrist. A Doppler ultrasound study of the blood vessels of the lower legs, called an ankle brachial index test, can assess how well blood is flowing to the feet. This is also painless and takes about 20 minutes. If arterial disease is present, it is treatable. Medications, lifestyle changes, and in some cases procedures can improve blood flow significantly, but only if the problem is identified. Let me tell you about one more person, because her story is the one that deserves to close this conversation. Helen was 69 and had what she considered a minor complaint. Her feet tingled at night. Not badly, just enough to notice. She had mentioned it twice to her doctor over the past 2 years, and both times she had been told it was probably related to her circulation or possibly her back. Her blood sugar had been borderline for about 3 years, hovering in the prediabetes range, and she had been advised to watch what she ate. She was not formally diabetic. She did not think of herself as someone whose feet were at risk. She assumed the serious foot problems she had read about were for people with advanced, poorly controlled diabetes, not for her. She developed a small callus on the ball of her right foot that she trimmed herself with a callus shaver she bought at the drugstore. The trimming went slightly too deep. She felt nothing. Over the following 2 weeks, the small wound beneath the trimmed callus became infected. By the time the smell of the wound alerted her that something was wrong, the infection had reached the soft tissue beneath the skin, and she required hospitalization and intravenous antibiotics. She kept her foot. But the road from a 2-minute bathroom decision to a hospital stay and 3 weeks of wound care took 4 weeks and a profound rethinking of how seriously she treated what her feet were telling her. Helen's story is not extreme. It is one of thousands that happen every year to people who are in the gray zone of blood sugar, who do not feel like proper diabetics, who have been told to watch things without being told specifically what they are watching for or why the consequences of missing it are as serious as they are. So let me be as clear as I know how to be. If your feet tingle at night, do not dismiss it. If the soles of your feet burn in the evening, do not dismiss it. If your feet feel strangely cold when the rest of you is warm, do not dismiss it. If you notice that hair has thinned or stopped growing on your toes or lower shins, do not dismiss it. If your toenails have thickened or changed in texture, do not dismiss it. If a small wound on your foot is taking longer than 2 weeks to heal, do not wait another week. If your feet have gone from uncomfortable to strangely quiet, do not mistake that silence for improvement. Your feet are speaking the earliest language of a blood sugar problem that may have been developing for years. They speak first because they are farthest from the heart, because their nerves are the longest in the body, because their blood supply is the most vulnerable to the changes that glucose drives. The damage does not happen overnight. It builds slowly, in silence, in the dark, in the specific and measurable destruction of myelin and capillary walls and nerve fiber insulation, one glucose spike at a time, over years. And the moment you recognize it for what it is, the moment you stop explaining it away and start treating it as the clinical signal it actually is the moment the trajectory can change. Your feet told you something first. Listen to what they are saying while the listening still makes the most difference. Take care of yourself.